sorry.
Okay.
If I move this up slightly, is that going to ruin it? It just feels really far back.
Do I right stand for it?
No.
Well, it could be together.
Okay. No, Lisa, you don't have to. If you could, just try to stay somewhat in front.
Okay.
Because we're live.
You don't want me walking all around the room.
No. If, anywhere on the front, because otherwise Christina's going to have to.
Where's she going now?
Yeah. And she's taping you your portion for on a separate camera that we can use specifically for.
Oh, okay. I don't think you
Just so you know.
Okay.
Morning. A couple things. So this is the stuff on people's desks. I ran out of these for the standing station in a couple weeks. So they can let us know if they like this to them. But everyone has this. And then on Facebook. I have more sitting there. I have 65. Okay, right. We don't have enough days. I have more upstairs, but I didn't have enough. So we need to do your Yes, I made sure of it. Everyone, but I know. So everyone can get a choice, and then the winner bag is the coach. So everyone gets a double. Not everyone gets a computer rolling computer. Okay. Thank you, Katie. Yeah.
Oh no. That and we try to make it. We fall asleep. Yeah. Are you ready? I was just going to Oh my gosh. Okay, I'm ready now. All right.
Good morning. Thanks for being here this morning. My name is Holly Brenner, and I do have the privilege of serving as our Senior Vice President of Strategic Development and Marketing, and I am very glad to be here with you this morning. This topic is always a very well-attended one. People are interested in it, and we've got a great presentation planned for you again this morning. But before we get started, we have a couple of housekeeping things. There are a number of things on your table, or on your standing table in the back. I will draw your attention to the schedule of the events. This keeps getting updated as we have more programs confirmed for our No Go Friday session, so please take that with you and put it up on a board or wherever it's easy for you to see. There's a $5 coupon here for our pharmacies. That should be at everyone's place. There's also a $5 coupon for the health shop. Now there are a couple of tables in the back. I understand that we ran out of these, so if you are interested and there's not one at your table, please just come see us after. We can get you one. Of course, the yellow feedback form. I haven't been getting too many of these lately, so if you have some feedback and some thoughts, we'd love to hear from you on that. We try to incorporate what you tell us, anything from, well, there's not a lot I can do about the temperature of the room, but the different programming topics, we try to incorporate things that you're interested in, make sure that they're on the agendas. And then finally, a green slip if you're interested in receiving credit for being here today, or if you're interested in winning that black bag. Good news though, we have some other Agnesian healthcare duffel bags, and I understand we have enough for everyone in attendance today. So it's a lucky morning. We do have a video reflection, but I think I'll go ahead and do the introduction. Should I do the introduction and then the reflection? What do you think, Katie? Perfect. Okay, we'll do the introduction, then let the reflection, and lead right into the presentation. So we do have two presenters with us today, Lisa Michaels, and Lisa, many of you know, she's the genetics specialist, a nurse practitioner, but specializes in genetics at the Cancer Center. And Dr. Michael Vanderkoy is here with us this morning, and Dr. Vanderkoy, as we know, is the radiation oncologist, or one of our radiation oncologists over at the Cancer Center. So Lisa works with our Cancer Center team, and she really helps the patients to manage their symptoms that are associated with all of their cancer treatments. She also works with our surgeons and radiologists and a number of other folks to help identify individuals ahead of time who are at increased risk for some different types of cancer. And her passion, as I understand it, is really in the detection of this cancer and prevention of cancer, as well as monitoring the survivorship. We run our survivorship program, or at least very involved in that. So that's very special too. And Dr. Vanderkoy his story is really interesting. I always find it interesting to understand and to learn why people choose the career paths that they do, and his story is no exception there. Dr. Vanderkooi's grandfather was diagnosed with colon cancer, and that's when Dr. Vanderkooy said, you know, this is something I really am interested in and would like to help others. The uncertainty, he shares that the uncertainty around the cancer diagnosis and his grandfather was very anxiety producing for his family, and he reflects back on that when he's working with his patients and working to educate them and help them to understand, really eliminate any questions to the best of his ability. So I think that passion is probably a great part of what makes him excellent in what he does. So we appreciate that. Dr. Vanderkooy has been here at Asian Healthcare since July of 1998. And I will now flip it over to the reflection, and then we'll go right into Lisa. Thank you.
In November, I did go to have my routine mammogram. And as I got to St. Agnes Hospital, the tech there had informed me that they did now have a 3D mammogram available at St. Agnes. I didn't know if it was going to get paid for, but I checked it out and found out it would be an extra $60. And to me, my life was worth a whole lot more than $60. And I chose to pay it myself and just go that route. The next day, I did find out after that they found a lump. And of course, I went in for an ultrasound. And then I continued on with a biopsy and found out that it was cancer. And with the help of St. Agnes Hospital and the doctors, we had breast surgery, just a lumpectomy. After that, I had 30 treatments and finished up on my 71st birthday, and I feel just great, and everything is in the hands of my physicians.
Good morning, everybody. Can you hear me okay? So I'm sure most of you know me. I'm Lisa Michaels from the Cancer Center. I've been with Agnesia now for about 26 years. Hard to believe, but I loved my journey so far, and it's only going to get better. So want to make a comment about Julianne. She's one of our little warriors. If you can see these women and other patients who go through various cancers, but she had her little ribbon pin on. And so we just love when these people go through what they go through and then talk to the community about it. So we really appreciate her for doing that. So I'm going to be talking to you today about genetic testing, and we know that there are some things that predispose us to cancer. There's things that we have in our control, and there's things that we don't have in our control, and that's some of the things that we're going to discuss here today. So actually, with cancer occurrences, they can be sporadic, familial, or hereditary. So sporadic meaning just what it sounds like, they just happen, okay? These are usually cancers that somebody may say to you, well, I don't know, how did I get this cancer? There's nothing in my family. Well, we know that cancers can just happen. We know that 1 in 6 people can get breast cancer, 1 in 8 people can get colon cancer. It just happens, okay? Familial cancers are cancers where you see them in a family. So somebody might say, yeah, my dad had prostate cancer, his brother had prostate cancer. They may not have been at a young age, okay, but we do see that there's a link with other members in the family having a cancer diagnosis. And then hereditary. So hereditary is not very common. And this is the one that I typically have been asked to deal with patients about, because we're looking for, is there a genetic predisposition with these people? So hereditary cancers obviously pass down from parents to children, grandparents to parents to children. You can see a complete linkage in the different generations. A lot of times these cancers are more aggressive in nature. They happen at younger ages, but again, not common. I would say that about 5 to 10% of all cancers we diagnose are because of a gene mutation. So thus, not very common. This kind of gives you an idea, a little bit easier to look at a pie chart here. So if you look at the sporadic part, so 70 to 80% of cancers can be sporadic. They give us about a 3% lifetime risk. But when you look at over here, the hereditary part, again, even though not common, look at how that bumps up your lifetime risk of getting a specific cancer. And then again, familial, again, about 15 to 30% lifetime risk if we see that there's multiple cancers in the family without a genetic predisposition. So we know that cancers happen as a result of abnormal gene expression. Okay, something just mutates in the gene, whether that's something that is genetic, again, meaning that's passed down through the DNA, or sometimes they're just what's called somatic. They just happen. Okay, something happens within our own gene structure that something mutates, and thus a mutation occurs. But what happens is with the DNA, we have a series of amino acids, okay, that make up our DNA. And what can happen in a specific mutation is when you have, say, 2 amino acids that are flip-flopped, or maybe one's deleted, or it's duplicated, then this codon here that we talk about kind of doesn't allow our DNA to read right. And so what can happen is that it can actually stop at that point and can no longer do its job. So when I go ahead and I start talking to you guys about some of these genes are genes that we all have, okay, men and women, we're all born with them, and they're called tumor suppressor genes. So what they're supposed to do is control normal DNA replication, okay? And when they can't do that, because maybe one of these codons got read wrong and the amino acids got messed up for some reason, that stops. If that gene can no longer control normal DNA replication, then what happens is like the floodgates are opened, and these cells can keep dividing, keep dividing, keep dividing, and thus predispose people to tumor formation. So to give you an example of some of the cancer syndromes that we deal with, you know, we talk about breast cancer. You know, the main ones that people know about is this BRCA1 and 2. And why? Because Angelina Jolie had it, you know, so we all hear about her. But this is an example of hereditary breast and ovarian cancer syndrome. So these genes here, as you can see across the bottom, general population risk for breast cancer by age 50 is about 2%, which obviously, as we know, as it goes up, as we age, the percentage goes up just because we're aging, okay? But if you have this mutation, look at how by age 50, your 2% risk jumped to 50%. And by age 70, your 8% risk jumped to 87%, okay? We also know that these women are more prone to developing a second breast cancer, almost as high as 30% or higher within the first 10 years, okay? This one says by age 70. We know that if somebody is diagnosed with breast cancer at 40, her risk of getting a second breast cancer by 50 is 30%. So that's why when we have people that are diagnosed with breast cancer, and maybe they have a big family history and they're referred to me for genetic testing, this is what we want to know, if they have these. Because this will influence what we do for surgery. Because if somebody is going to have that high of a risk for a second breast cancer, more than likely they're going to want to probably have a bilateral mastectomy so that they don't need to go through this again. These also can be associated with, as you can see, the ovarian cancer. And although you know, ovarian cancer is pretty low risk for most of us, under 1%. But when you look at it, goes up almost 40% risk if you have one of these mutations. It's also associated with melanoma, pancreatic cancer, prostate, and male breast cancer. Now, I'm going to talk to you about BRCA1 and 2, but the one thing that I want you guys to realize is that because of all the information and research that goes into genetics recently, we know now there are so many other genes associated with breast cancer. And what's frustrating for me is that I'll have providers or patients come to me and say, well, I don't need any more genetic testing because I had BRCA1 and 2 testing done and I'm negative. Well, good for you, that's great, because we know that BRCA1 and 2 is about 70% chance if there's a cancer, it's going to be from BRCA1 or 2. But now we know 30% of the time it can be from a different gene, okay? And we're finding now there's other genes, CHEK2, POLB2, ATM, these other genes that can predispose women to breast cancer. So what's happening now is that people are learning about this. And say they had breast cancer 10 years ago, they had BRCA testing done with negative, they're now coming back and saying, hey, can I have a reflex test for these other genes? And so we've been doing that, and unfortunately, or fortunately, I have been finding some mutations. So we know that research is working for us, okay, in identifying these genes. What's interesting, is that it took 15 years for us to know what we know about BRCA, and it's taken 5 years for us to identify 12 more genes. So that's how fast our research has been developing. So when I meet with people, I need to make sure they meet criteria for testing, because this is about a $6,000 test, okay? And I know people are worried that I don't even know if I want to go through this because I don't want to be stuck with a bill. Well, we try to tell them, you know, you're not going to be, okay? Because when you meet with me, it's pretty much just an office visit, like a doctor's appointment. We're talking about family history. I want to make sure you meet criteria, okay? For affected and unaffected people. So when we look at criteria, interesting, we know that Ashkenazi Jewish descent are at risk for breast, ovarian, and pancreatic cancer, okay? And that's just because we know that the Ashkenazi Jewish, that 400 people became 4 million in 30 generations. So we know with all the consanguineous relations with other different divisions that predisposes people more to mutations. So actually, in people who are even unaffected, if you're just Ashkenazi Jewish, you automatically meet criteria for testing because they have such a high prevalence for mutation, for BRCA. If somebody already has a known mutation in the family, they meet criteria. Again, early age of onset, triple negative. Triple negative is an aggressive breast cancer. We look, as providers, we look for expression of estrogen and progesterone and a human epithelial growth hormone called HER2/neu on the surface of breast cancers. And we hope those are present, because when those are present, we have more opportunities to treat people. If those aren't present, obviously it's a worse prognosis, okay? So triple negative tends to be in BRCA people, okay? Again, if somebody had 2 breast cancers diagnosed in the same person, an ovarian cancer, a male breast cancer is a big red flag, okay? And then breast cancer at any age, plus maybe one of these other patients, like somebody had a pancreatic cancer in the family, okay? So that's what I look at when I'm trying to determine if somebody's going to meet criteria for testing. That's the affected. The unaffected is pretty much the same. The only problem with this is that when you get into the unaffected, you have to deal more with age. So for example, you don't have breast cancer, but you have to have at least 2 close relatives and one of them has to be diagnosed under 50. Okay, or you had, this one says 45, they've now changed that to 50. Again, you may say that you have lots of family history on both sides. Well, you really need to look at one side, because if you have 1 person here and 2 people here, you still might not meet criteria, because you can't add them up. You can't just say I got 3 people, because they're coming from different sides of the family, okay? So again, these are just things that I go through with patients when I meet with them. This is an example of another syndrome. This is called Li-Fraumeni syndrome, and interesting enough, we do have a 48-year-old that we care for that has this, okay? This is a very disturbing syndrome to have. It's a mutation in this gene called TP53, which is pretty much one of the biggest regulators of our DNA that we have. And so if you have a mutation in this one, this puts you at predisposition for many cancers. In fact, the gal that we take care of has had endometrial cancer, a sarcoma, and I can't remember what the third is, all by age 42. So these are the big red flags that you're looking at. These people, again, the risk of developing invasive cancer is 50% by age 30 and 90% by age 70. So these people, a lot of surveillance. It's sad. I mean, you see them and it's like, did you get your mammogram? Did you get your skin exam? Did you get your ovarian exam? Did you do this? Did you do that? I mean, it's very daunting for some of these people. But again, good to know, because obviously there's things that we can do and increase surveillance in order to decrease the risk of getting another cancer. Cowden's is an example of a mutation in this tumor, or this gene here called P10. This is interesting. When you look at what I have written up here, multiple hamartoma syndrome just means that these are little like benign tumors that people may have. They may be Hamartomas can be in the colon, they can be in our skin, they can be in the breast, they can be other places. So when somebody has, for example, I got a referral for a patient to do this because they did a breast biopsy on her, and the tumor was a hamartoma. Not very common. So the radiologist starts to wonder, do they have a Cowden syndrome? Okay. Interesting enough, people with Cowden's tend to have macrocephaly. So when I meet with these people, I do a head circumference. They're pretty taken aback, wondering what the heck I'm doing. But there is a direction with women who have head circumference more than 58 centimeters. Now don't go back and everybody measuring everybody's head. Because you're going to know, when you look at somebody, you're just going to know that their head looks a little bit bigger than normal people. But anyway, but they also tend to have a lot of these other skin findings, okay? Again, very interesting, not very common, okay? But again, just to give you guys kind of an idea of, you know, I'm not looking just for breast. We're looking for other types of tumor syndromes, okay? Lynch syndrome is probably one of the ones that maybe more people have heard about. Lynch syndrome is what's called a hereditary non-polyposis colorectal cancer. And you're going to impress everybody when you say that. But what it obviously means is that these are cancers not coming from polyps, okay? And what's interesting with Lynch is that they tend to be, 2/3 of them, in the proximal colon. So they tend to be right-sided colon cancers, okay? They also can be associated with other cancers such as endometrial, ovarian, kidney, pancreatic, on and on. So for this one, I had an 82-year-old lady that she presented with a breast cancer. Okay, you know, not, I mean, a big deal, but you know, 82, you're thinking, okay, you know, we can deal with this, and boy, you're really lucky that you're 82 and you haven't had other issues, and well, I have. So she had endometrial cancer at 40, colorectal cancer at 60, and now breast cancer at 80. So then you start to wonder, okay, this doesn't really seem fair for you, and maybe there's something going on. And so thank goodness her one son was a pediatrician, and we started talking about Lynch, and he goes, oh mom, I really think you should get testing. So we did, and sure enough, she has a mutation in MLH1, okay? Which again for her, maybe at her age, maybe she won't change a lot, okay? Because we know like when we get older, colon cancer surveillance could be dangerous for older people. And she already doesn't have her uterus, but for her kids to know. So she's got 3 kids, okay? And what I think is funny is she's got 3, the daughter is negative, the pharmacist is positive, and the doctor still hasn't been tested. Typical. Anyways, but just to kind of give you an idea, we do have these syndromes around us that exist. We actually have quite a few people in Fond du Lac with Lynch syndrome, okay? This kind of just gives you a little bit more specifics about the average age of diagnosis. So endometrial cancer by about 46 years of age, ovarian cancers could be about 42 years of age, gastric cancers by 56 years of age. So this one, another tongue twister, familial adenomatous polyposis syndrome. So these are ones where you see patients having multiple polyps. Multiple polyps. I mean, like, if they did a resection of your intestine, the section they take out looks like a Berber carpet. It's just polyp, okay? So these people, again, at very high risk. 7% by age 21, but look at 87% risk of cancer by 45, 93% by age 50, okay? Now, you don't really see this very often. But what I do see, what I test for more, is this thing down here called attenuated FUP. So this is, I mean, it's a mutation, but they call it flawed, okay? So for these people, you don't see the 50s to 100 polyps, because that's what you have to, actually criteria for FAP is like they have to have had 100 polyps, okay? But for attenuated, they have to have 30. That still sounds like a lot, but I've met with people that have had that. It doesn't have to be at one time, but they have to have had about 30 polyps over about 2 or 3 colonoscopies, okay? And then obviously we go and we test for that. And unfortunately for these people, what are you going to recommend? A colectomy? I mean, that's when you start talking about what is your quality of life, versus what do you want to do for surveillance? Do you really want to live with a colostomy all your life? But these are conversations that we have. Again, just another one that kind of gives you an idea that we also look at, there could be dermatological changes in people and other things that you look for when you're questioning if somebody has a certain syndrome. So this one is called the Hamartomatous colon syndrome, or Peutz-Jeghers, which is a mutation in this STK11. As you can see, this one, it can be associated with polyps throughout the GI tract. So a lot of times people have upper endoscopies, and you don't really hear about having a lot of polyps in the stomach. Maybe somebody with this does, okay? They also can have this perioral melanin pigmentation. So again, when I meet with people, I'm not just asking them, I'm doing an exam. Checking their head circumference if I'm thinking Cowden's. I'm looking in their mouth, okay? I'm looking at their eyes. You're making sure they don't have these unusual pigmentations, bobs of the feet, freckling on the lips, and not just on the lips, inside their mouth, on their tongue, on the sides of their mouth, sides of their cheeks, okay? So this can be associated with colon cancer, pancreatic, stomach, as you can see down here, small intestine, so quite a few different cancers. I actually have a gal with this mutation. This is called juvenile polyposis syndrome. And we unfortunately, or fortunately, because she is an angel and she is so inspirational that she has changed many of our lives at the Cancer Center, but we have a 27-year-old who was diagnosed with stage 3 and even questioning if she was stage 4 colon cancer. And again, she's been an inspiration to us, but when talking with her, she noted that she did have some issues. She remembered when she was young, and her mom remembered that she had GI issues, and they did find some polyps when she was like 9, okay? And she had some family members with polyps. So we did testing on her. She's got this SMAD4 mutation, okay? So her risk of colon cancer is 50-fold. She's only 28 now. So when I talked with her, the big dilemma was, what should I do? Do I live with a colostomy? Do I just do surveillance? And I'm happy to say she has fully recovered. She's had a complete colectomy. She's doing well. She's glad she's done it. Family's glad she's done it. But she's my little SMAD4 girl. We love her. Neurofibrosis. This is one I wanted to show you guys a picture, but they thought it was too gross to show. But it's interesting, and I have a patient that has neurofibromatosis. So again, this is a mutation in NF1 or NF2, okay? It's also called von Recklinghausen disease, okay? Now these are people that can have these multiple cafe au lait spots, which is that people call them like maybe a birthmark. It looks whitish, and then it may have like a darker pigmentation around the outside of it. But they also can have these neurofibromas. And unfortunately, these people who have this, it's very sad because, you know, to look at them, you know, they really do have, like again, multiple nodules and these like tumors. They can be all over their face, all over their body. They can actually get it like in their ears, in their vagina, in their rectum. I mean, it's very sad. And they also can have an association with brain cancers. And unfortunately, one lady I had, her son recently passed. He had it too, but he had developed CNS, or central nervous system, complications from it. So, real quick, because I don't want to cut into Dr. Vanderkoy's time. He's like, maybe you should. He's got fun pictures. I just talk. Anyways, but for my high clinic, or my high-risk clinic, so I meet with patients that are affected and unaffected with cancer. The patients that are unaffected with cancer, what I pretty much say to them is this: let's review your personal history, let's review your family history, okay? If you do not meet criteria for testing, I still want to do this high-risk assessment with you guys. Because what if we do testing and it comes back negative? It doesn't mean that you're still not at risk because of personal and family situation, okay? So let's do this. So I pretty much go online with them in the room. We have a couple different risk models we do. One's called a Gale, a Trevor Cusick model, and the other one's called the Gale model. And what these ones do is they look at mammographic density, they look at if you've had children, how old you were with your children, your height, your weight, when you started menstruating, family history. Did you ever do hormone replacement therapy? Did you ever have a breast biopsy? And what it does then is it calculates what their lifetime risk would be of developing a breast cancer based on those attributes. Nothing with genetics, okay? And what the American Cancer Society states is that if people are deemed to be high risk, meaning over 20% lifetime risk, then they meet criteria for additional imaging. Additional imaging is like a breast MRI, rotating with the mammogram every 6 months, okay? The Gale model is one that we look at what would be the benefit to these patients to give them chemoprevention. Chemoprevention is when you take a pill like tamoxifen that we give breast cancer patients, and we give it to people in high-risk categories for 5 years, okay? We know that if we give these people those for 5 years, it'll decrease their risk of developing an invasive breast cancer by 50%. So what I do is I look at what a woman's 5-year risk will be. And if her 5-year risk is about 3%, I recommend tamoxifen. So we look at that. So again, even if genetics would come back negative, it doesn't mean there isn't something we can't do, okay? We talk about low-dose aspirin in people who may have a family history of colon rectal cancer, okay? Because low-dose aspirin can be chemoprevention for colorectal cancer. But we look at the risks and the benefits of all these because they're not going to come without side effects. And they're not for everybody, okay? So that's why you have these counseling appointments. So we can go through that and to weigh the risks and the cons. I think I pretty much, went through that. Again, that's the main gist of the high-risk clinic. If we do testing and it comes back negative, I pretty much call the patient and say, great news, it's negative. Send them out the information. When you get it, if you have a question, call. If they're positive, we get them back in. We go through the results together. We go through what the recommendations are by NCCN guidelines, and we go through what you should do for your family members. And we talked about that. I think that's it. We'll be on to Dr. Van der Kooi. Thank you. Real quick, I told him to wear pink, but as you see, the Packers won out yet again.
Thank you so much, Lisa. We're so blessed to have Lisa at the Cancer Center doing our genetic screening on our patients, and what a blessing we have, and such a great community to have Lisa. So, well, first of all, I want to thank administration for inviting me today, and I also want to say that it's Breast Cancer Awareness Month, October, so it's important for patients to get annual mammograms because, again, screening is so important in our field. Screening, which is yearly mammograms for women beginning at the age of 40, screening, which is colonoscopy, beginning at the age of 50, is so important because we're catching these malignancies at an earlier and earlier stage where they're quite curable. So it's Breast Cancer Awareness Month, and we should all be aware of the importance of screening. So today I have a few minutes to talk about some of our advanced technology at the Cancer Center in the Radiation Oncology Department and how we're using this advanced technology to improve patient outcomes and reduce the risk of short-term and long-term side effects. So first of all, I just want to let you know how blessed we are here at Ignesian Cancer Center to have a lot of the great technology they have at academic centers. One of the academic centers that we look at often in cancer treatment is Harvard out in Boston, Massachusetts. And today I'll be concentrating on 3 areas of advanced technologies that we have. Stereotactic body radiation therapy. I will also be talking about optical surface motion management systems. And I will also be talking about a robotic couch and how all of these things, we use all of these things to treat the patient and try to minimize the risk of short-term and long-term side effects for our patients, and thus improve long-term outcomes. First of all, I'd like to talk about optical surface motion management systems. I went into radiation oncology because I love treating patients and I love improving outcomes. But unfortunately in radiation oncology there's a lot of acronyms, so this is one we use, OSMS. So optical image guidance is what we use in radiation oncology and to improve safety, precision alignment, and real-time sub-millimeter movement monitoring. Now we use this in a lot of different malignancies such as breast cancer, lung cancer, head and neck cancer, and primary brain tumor treatment. I have a little video here because a lot of what I'm talking about today is very visual and you have to visualize it. So in summary, what optical image guidance is being able to position the patient real time every day. We have a very complicated infrared camera system in our linear accelerators. We're able to watch the patient once we get them set up within certain parameters. The patient has to come be still or be at a certain position for the machine to be activated. If the patient were to go out of that position by even a millimeter, the machine would automatically turn off. So it's a real-time tracking of the patient to make sure that we're giving them precise treatment by less than a millimeter every second they're getting treatment. So I'd like to play this little video and kind of explain it after we play it. This is about optical surface motion management systems.
Are you concerned about patient safety?
Margins of expansion on targets are generally quite tight, so even a small amount of movement in patient or target can result in a substantial deviation in delivered treatment from that which was intended. Real-time tracking of motion can ensure that delivered treatment is as intended or prescribed.
And as we know, 1 cm movement is a big deal at the time of treatment. However, 1 cm is just this tiny bit. It's very easy for a patient to move on the table.
The accuracy of radiation delivery has increased significantly in recent years. Advanced methods are now being used in the clinic for precise patient setup, including a line-RT for fine-tuning patient posture and position, and onboard kilovolt imaging for localizing the internal target. On completion of setup, the target and patient are optimally aligned, ready to receive an accurately delivered dose to the correct location. Did your patient move? Knowing where your patient is makes all the difference. A line-RT monitors patient motion continuously throughout treatment and holds the beam automatically if any motion exceeding user-defined tolerances is detected. Through either asking the patient to relax or by adjusting the couch using a line-RT's position correction and couch control functionality, the patient is returned to their correct position and treatment may resume. Any slight movements, such as patient coughing, are detected during treatment without necessarily requiring delivery to be interrupted and the therapist to re-enter the room. The beam is automatically held if the patient's position moves outside a user-defined tolerance and is re-enabled on its recovery. Treatment continues with a line-RT monitoring the patient throughout, providing the reassurance that patient position is maintained until the completion of treatment.
We're looking forward to investigating the system as a method to really not only set up the patients accurately with 0 dose, but also monitor them during the entire treatment. So if they move, we can provide a beam hold by the connection to the interface at the console. So in that sense, there's really no chance for you to mistreat the patient because once you set them up accurately, it's integrated into your treatment console And if the patient moves out of your preset tolerance, then you automatically initiate a beam hold. So it's really the ultimate in high precision treatments and also patient safety.
So as you can see by the video, this new technology that we have really allows us to treat the patient. And again, if the patient moves or coughs at all, the machine automatically turns off. So from a patient safety perspective, it is unbelievable technology that we have here at Ignitian. So I just want to demonstrate to you a few clinical cases where this is important to us. This is common in a lot of our breast cancer patients, especially many of our breast cancer patients will receive adriamycin-based chemotherapy, which can be cardiotoxic. And so it's very important to minimize the heart dose to our patients. So this is rendering, I don't know if we can get the lights off a little bit. It's hard to see here on the screen, but this is a rendering of one of our patients who had a CT, thank you so much, CT scan, and a rendering of, we do our CT simulations where a patient has a kind of standard breathing, and we do a scan, and then we do a scan with a deep inspiratory breath hold. And you can see here, this is the patient's heart. This is their left lung. This is the front of the patient. This is the left side of the patient, and this is the back of the patient. And you can see here with free breathing how the left ventricle of the heart comes very close to the chest wall. And when we're treating the entire left breast, we come with a medial tangent field and a lateral tangent field on how a portion of the heart may be in the field. Well, it's great because we can use a deep inspiratory breath hold with that. With the patient taking a deep breath in, the heart is then pushed more medially, and this becomes all lung. So we literally can push the heart away from the target volume of the left breast and left chest wall and treat the left breast alone with treating really no heart at all. And so we can use the deep inspiratory breath hold and use the optical image guidance system where the patient has to be in the deep inspiratory breath position to deliver the treatment. Thus, we're treating the breast cancer and minimizing any treatment to the heart. So this new technology of optical image guidance is very important in a clinical situation like this. Other clinical situations where the optical image guidance is really important is when we treat some of our brain tumors or head and neck cancers. This is a very interesting patient who has a right optic nerve meningioma. So they have a tumor on their right optic nerve. This is the front of the patient. This is the right side of the patient. This is the back of the patient. This is the patient's right eye. This is the patient's right optic nerve. So the tumor is actually within the right optic nerve. It could not be, it was only biopsied, it could not be removed completely because of the risk of permanent blindness and damage to the right optic nerve. So in this case is challenging because we have to treat the right optic nerve and try to minimize treatment to the right eye, especially the right anterior eye, and the cornea, sclera, lens. And we want to also minimize treatment to the brain. Here's the brain. And we also want to minimize treatment to the optic chiasm. This is the optic chiasm, which controls the vision, both the visual fields in the right eye and left eye. So you can see this is our high dose area of radiation, how the dose rapidly falls off. You can see in this situation how important it is to use optical image guidance. So we monitor the movement of the patient, because if the patient were to move a few millimeters this way or that way or back, how this high dose area would then start encompassing the brain or the optic chiasm or even more parts of the eye. So that's where optical image guidance is so important when we deliver the treatment. If the patient's not within certain parameters, the machine automatically shuts off until we get the patient back in the perfect position again. And this is another CT scan showing the meningioma patient, showing the right optic nerve meningioma in relationship to the brain, and how any movement could move these high dose areas into vital areas of the brain, including even the frontal lobe. And this is a sagittal view. This is the front, this is the top of the head, this is the back, showing the high dose area on the right optic nerve and how it's so important to keep that high dose area on the optic nerve and try to minimize treatment of the anterior eye or posterior brain or optic chiasm, and how by using the optical image guidance system we can monitor the patient real time every second they're under treatment, and the machine will automatically shut off if they're not within certain parameters. Now, another area, site where it's really important to use optical image guidance is head and neck cancer. This patient is a pleasant patient with a base of tongue cancer that has metastasized to his right neck. And this is kind of a complicated projection, but to try to summarize it, this is the top of his head, this is the right side, this is the left side, and you can see here this mass. This is a lymph node involved with squamous cell carcinoma. And so this is technically challenging because we have to give a very high dose to the head and neck mass and lymph nodes and try to minimize dose to normal critical structures like the vocal cords, which are here, and try to minimize dose to the spinal cord, the parotid glands, and other normal critical structures. And again, by using our optical image guidance system, we can treat the patient and the machine will automatically shut off if we're not within certain parameters. And this is a sagittal view. This is the front of the face. This is the back. The top is up, or the superior aspect is up here, and the feet are down here. You can see the base of tongue cancer right here, and you can see all the normal critical structures very close by, including the spinal cord, the brain, the oral cavity, the lips. This is the vocal cords again, and how it's important that we keep the high dose area here by the tumor and try to minimize any movement, because with any movement, this high dose area can drift towards the spinal cord or the anterior oral cavity, or it can drift near the vocal cords. So again, having the quality assurance and the sensitivity to set these parameters very tight so the patient, so if the patient were to move, the machine automatically shuts off is so critical. So that was optical image guidance. I'd like to talk about another great tool that we have in our cancer center as far as treating the patient and minimizing toxicity. It's our robotic 6 degree of freedom table. The benefits include precise tumor localization. We can use stereotactic radiation therapy with this, and we can do complex positioning ability, pitch, roll, yaw. So to summarize this and not get too complicated, we can move the patient with a robotic table by millimeters, anterior, posterior, left, right, superior, inferior, and then we can do different complicated tilts of the table to make sure that we get the patient in perfect position. Because many of our patients we do daily cone beam CT CAT scans on every day. So we do a cone beam CT CAT scan on them, position their tumor just perfectly into our plan, and by then with the movement of a robotic table, get them into perfect position and then deliver the treatment. So the 6 degree of freedom table is so important in, again, assuring the patient's in the perfect position every day by using our cone beam CT CAT scans every day to position the patient, using a robotic table to get them in just the perfect position, and then delivering the treatment quickly. So we have a short video on the robotic table. And if you could play that now, it would be great. You can see the table moving. This is pitch rolling along. You can see the way we can position the patient. All the different array of movements. We did not do that when I first started here. This is great technology. I could sit here hours and just watch this video. Sorry, I just read it right. You can show it's just great. It's fantastic. So how can we use this robotic table to treat our patients? This is a very interesting case. This is a patient of mine with a head of pancreas cancer. And what you see here is a stent. Unfortunately, the head of the pancreas cancers will typically compress the common bile duct, which goes from the liver to the small bowel, to the duodenum. And so you may see people in the hospital who are jaundiced or have painless jaundice, and this is unfortunately one of the things that can cause painless jaundice is head of pancreas tumor compressing the common bile duct. So the common bile duct was decompressed with the stent, and so we can use both the stent and the robotic table to get the patient in perfect position every day. So what we do is we do a CT simulation where when we set up the patient initially, we give them oral contrast to help better visualize the stomach and the small bowel. And we do a CAT scan, we do our pinpointing, and my physicist and physicist assistant do the treatment planning where we come up with a beautiful treatment plan to treat the cancer in the head of the pancreas and minimize treatment to normal tissue. And you can see the normal tissue. There's the liver, you have the stomach, the spinal cord is just behind here, and the kidneys I'll show you in another projection. So there's a lot of head of the pancreas cancer treatment is very challenging because there's a lot of normal critical structures within millimeters of it. So in this particular patient, what we do is bring the patient into the treatment room. We do a daily CAT scan on them every day, a daily cone beam CT scan. And we overlap our daily cone beam CT scan with this planning scan. And we use a robotic table to position the patient to match the scan so they get in just the right position every day. And once they're in the perfect position with a robotic table, then we deliver the treatment quickly. And this is a sagittal projection of the same patient. The patient's head is up here, the front of the patient is here, the back of the patient's here, and the feet are down here. So this is the stent in the common bile duct. There's cancer around that compressing the stent. And this is our high dose area here. And you can see with our high dose area here, if the patient, if there was movement, we'd be irradiating a lot of normal critical structures that we shouldn't, like the liver, the spinal cord, the kidneys. So it's important with a robotic table to position the patient just perfectly every day. Another site that we treat, that we definitely use the robotic table, is prostate cancer. This is a prostate cancer patient. Here's the front of the patient. This is a CT projection. Here's the back. Here's the left. Here's the right. And this is the prostate gland. We have the urologist place fiducial markers in the prostate gland to help visualize the prostate gland. Here's the prostate gland. Here's the rectum. Here's the left hip. Here's the right hip. And you can see our high dose area. We go to a very high dose, is right here. And the dose rapidly falls off as we try to block the rectum, left hip, and right hip. So again, we do a cone beam CT scan in the treatment machine room every day, use a robotic cable to shift the patient by millimeters, and then deliver a very conformal, tight IMRT treatment to the prostate gland. Here's another projection of the prostate gland. This is a coronal projection. This is the prostate gland. This is the bladder. This is the left hip and the right hip. And you can see the tight conformal treatment dose to the prostate gland and how rapidly the dose falls off. So how important it is to be able to use a robotic cable to position the patient perfectly every day. And here's a sagittal view. Here's the front of the patient. Here's the back. The feet are down here, the head's up here. And this is the prostate gland here. Here's contrast in the bladder and contrast in the urethra. And this is the rectum. And you can see how the very, very high dose curves are treating the prostate and how the dose rapidly falls off. So we minimize treatment to the rectum and bladder. And again, the daily use of the robotic cable helps us position the patient precisely every day. One additional thing I want to talk about, I know we're running short on time, is stereotactic body radiation therapy. And this is a great new technology that we have at the Cancer Center, where we're able to reduce the number of treatments, give a large tumoricidal dose in 3 to 5 treatments. This can replace traditional surgery in select cases, such as early stage lung cancer, and it can reduce side effects due to a smaller treatment area of treatment. And again, this is our machine. I could just gaze at this for hours and fall in love again. So this is our machine with our robotic cable. This is our Varian TrueBeam machine, our linear accelerator. And this can deliver very high doses very quickly. The radiation comes out of the head of the machine. This is our imaging equipment. Our imaging equipment is not only X-ray, but we can do a daily CAT scan with our daily cone beam CT every day. And here's a model kind of side view of the machine and with the cable. And the radiation comes out of this area of the linear accelerator and imaging equipment on the side. And so I want to show an example of cases that we typically treat. So this is an early stage lung cancer patient of mine who had an early stage lung cancer. She did not have good lung function, long-time smoker, and so the options to treat her early stage lung cancer are surgical resection or stereotactic body radiation therapy. And with stereotactic body radiation therapy, we can give a very high dose to the lung. I should orient it here. Her head would be up here, her feet down here, her right side over here, and her left side over here. And you can see this, the mass here in her right lung. And this is the high dose area of the radiation here, and how we can deliver high doses of radiation to the lung cancer, and the dose rapidly falls off to normal critical structures, like her normal lung, which she has poor function, and rapidly falls off to avoid treatment to the spine, the spinal cord, which is here. And so again, stereotactic body radiation therapy, we can deliver 1 week of standard radiation dose in one treatment. So this patient was treated to 5,000 centigrade 5 fractions. So literally we're giving one large dose a day that we normally give over the entire week. And here's a sagittal projection. Here's the front, here's the back, the head's up here, the feet are down here. Here's a sagittal projection of the cancer and how we can deliver high doses to the cancer, and the dose rapidly falls off towards other normal critical structures like the spinal cord and normal lung. And again, with these patients, we use all the tools I talked to you about. So for a stereotactic patient, we definitely use optical image guidance to ensure they're in the perfect position every day. We use a robotic table. We use a daily cone beam CT to make sure they're in the perfect position every day for treatment. So some of our advanced technology in radiation oncology at Ignesian Cancer Center include the optic surface monitoring system, which I discussed, the robotic 6-degree of freedom table, and stereotactic body radiation therapy. And it's such a blessing to work at Ignesian Cancer Center. I've been here for 19 plus years, but the new technology that administration has given us has really allowed us to improve patient care in radiation oncology. And most importantly, it's not just the technology, it's the team. I am honored to work with Dr. Philippe Troike in radiation oncology. This is our physicist assistant, Phil. Our physicist, Tim, is also really integral in all of our treatment planning. These are our therapists, Brigitta and Brian. There's some that somehow didn't get in the picture. We'll have to work on that next time when we have a team picture. And then our wonderful nurses, Stacy, Mary, and Tammy. They're all an important part of our team. I see other team members here in the audience today are wonderful social workers and dietitian. We all work together in a collaborative effort, multidisciplinary effort, not only in radiation oncology, but with medical oncology and our surgeons to provide excellent cancer care. We are open in discussing all the cases together to make sure we provide excellent cancer care every day, but also safe, precise cancer care every day. So thank you very much for allowing me to talk. Oh, sure.
Wonderful presentations, thank you. So does everyone have their green slips turned in? Dr. Vanderquay will draw our lucky winner.
All right. Diane Sippo.
Diane, congratulations, Diane.